Sasha, we can't see anything.
It's coming.
Well, thank you, Andrew. Those of you who were watching our previous session will know that that too came from Andrew's laboratory here, Great Ormond Street, in the centre of London. And what we discussed with you in our earlier session was the concept of remodeling of the embryonic interventricular communication. And we pointed out that by that process of remodeling, the atrioventricular canal expanded, providing the right ventricle with its inlet, and then part of the outlet component was transferred to provide the outflow tract for the developing left ventricle. Now, what we're going to be discussing with you today is the concept of those processes going wrong, so that we have malalignment of those developing septal components. So that is going to be our emphasis throughout this session. What we're going to point out to you, however, is that malalignment can involve either defects that open to the inlet or to the outlet of the right ventricle. So that means it can affect the geography of the defect. More importantly, when we describe malalignment, since it can be either an inlet or an outlet defect, it follows that it does not account for the specific phenotype of the ventricular septal defect involved. So what we're going to emphasize is that whilst malalignment is a crucially important feature, we need to take account of that feature in addition to both the borders of the defect. We'll emphasize that it is the borders that determine the phenotype, and also the geography of the defect where it opens. So again, malalignment, when it involves the inlet, it's going to be between the atrial septum and the septum that divides the apical part of the right ventricle from the apical part of the left ventricle. And I'll be calling that the apical muscular ventricular septum. It's rather different when we deal with malalignment in the setting of outlet defects, because then it is the outlet septum that is malaligned relative to that apical muscular septum. Now, we're also going to introduce to you the concept of common or separate atrioventricular junctions, because Andrew will be showing you that those septal components can be malaligned in either of those settings. And it is the presence of common or separate atrioventricular junctions that can complicate double inlet, but malalignment itself can produce absence of one or other of the atrioventricular connections. So we're also going to be looking at that anatomy. But it all comes back to the development. Now, I hope you will remember that I showed you this in our previous session. It's a representation of the cavities of the developing heart at what we call Carnegie stage 13. It's about halfway through the 5th week of development. You're looking at the developing heart from the front, and there is the atrioventricular canal. And at this early stage, the atrioventricular canal is looking exclusively into the developing left ventricle. There, from the outlet part of the developing ventricular loop, you can see the beginnings of the apical component of the developing right ventricle. And at this early stage, the developing right ventricle is supporting the entirety of the outflow tract. This is what it looks like when we take a reconstruction. We can see the same thing in an episcopic data set. And here I've cut through the base of the developing ventricular mass. You're looking at it from the ventricular apex. And there you are seeing the underside of the atrioventricular canal. And this shows you how the atrioventricular canal is supported exclusively by the left ventricle. Now here is the focus of our attention. This is the primary interventricular communication. And you can see that all the blood entering the developing left ventricle has to pass through primary interventricular communication so as to reach the developing right ventricle. And the developing right ventricle at this early stage is supporting the entirety of the developing outflow tract. I also showed you this picture when we looked at these processes in our previous session. It's an oblique cut viewed from the right, and that is the cavity of the developing right atrium. I hope you can see the developing right atrium has no connection with the developing right ventricle, and that is why all the blood coming into the apical component of this right ventricle has to pass through the primary interventricular communication. And again emphasizing that at this early stage, the entirety of the outflow tract is supported by the developing right ventricle. Now this is what that situation looks like when we put the walls back on in our reconstruction. We're looking at it again obliquely from the right side, and in yellow there you see the atrioventricular canal myocardium. And you've seen just a moment ago that at this early stage, the atrioventricular canal is looking exclusively into the developing left ventricle. To emphasize again, the right ventricle is supporting the entirety of the outflow tract. Now if we look into the atrioventricular canal, we can see the atrioventricular cushions, and they are positioned superiorly, inferiorly. And at this early stage, they are not fused to each other. So that tells us that not only do we have a common atrioventricular junction, it also has a common atrioventricular valvar orifice. And this is the default for early development. So what we can say is that at this stage we have double inlet, left ventricle, through a common atrioventricular junction. And we would have that because there has been no transfer of the atrioventricular canal to the developing right ventricle. Now here's where we come across malalignment. We also need to take account of what is happening to the atrial septum, because the atrial septum can grow so as to fuse with the atrioventricular cushions, and that will separate the atrioventricular junction whilst it's still connected to the dominant left ventricle. So the development of the atrial septum will determine whether we have common atrioventricular orifice connected to the left ventricle or separate orifices joining into the left ventricle. But here is where we now see malalignment. Because if the atrial septum itself is malaligned, it can wall off the right atrium so as to produce classical tricuspid atresia. So let's look at that in a section from a developing human heart. You see here the right atrium, and at this stage, as we've seen, both it and the left atrium are passing through the common atrioventricular canal, supported exclusively by the developing left ventricle. You can see here, however, the beginning of growth of the primary septum with its mesenchymal cap. Now, if the primary septum grows centrally relative to the atrioventricular canal, fusing with those cushions, it will divide that atrioventricular junction into right and left atrioventricular valves, but still opening to the developing left ventricle. So that gives us the options you're going to see very shortly: double inlet left ventricle with separate atrioventricular valves, or double inlet left ventricle with common atrioventricular valve. But what happens if the atrial septum grows eccentrically and is malaligned? If it is malaligned to such an extent that it fuses with the right wall of the atrioventricular canal, then we will have classical tricuspid atresia with only the left atrium connecting to the developing left ventricle. But very rarely it could grow in the other direction, and then it would leave only the right atrium connected to the developing left ventricle. So these are the options that Andrew is going to show you very shortly. He's going to show you how we can have the atrial chambers connected only to the developing left ventricle in such a way that we have double inlet left ventricle with common atrioventricular junction, or separate atrioventricular junctions, or he's going to show you how we can have tricuspid atresia.
Let's start by looking at a heart with double inlet to the left ventricle, and you can see here that the heart, if I turn it in correct position, astutely correct position, you can see that actually there's a rudimentary right ventricle sitting on the shoulder of the dominant left ventricle. And I can show you the components of the right ventricle by opening up the free wall there, and you'll see the right ventricle has an apical trabecular component, which is coarse trabeculations, and also has partly an outlet component, although there is override of this arterial valve. So it has two of the three components, apical trabecular and outlet component. But if we look at the plane of the ventricular septum, you'll see this is almost horizontal, as we're seeing it on the screen there. And it is, as we'll see, out of alignment or malaligned with respect to the plane of the atrial septum. So let's have a look at the structure from the inside. Here you can see from the right atrium, you can see the pectinate muscles of the right atrium, atrial septum, and an AV valve coming on this side. And then on the other side, we've got a second AV valve. So there you can see a smaller left AV valve, which is also going into that dominant left ventricle and is leading from a smoothly walled morphologic left atrium. I can show you both of those in clamshell fashion, so opening up the heart now, and you can see the two AV valves next door to each other. What looks like a coarse ventricle, coarsely trabeculated ventricle, is in fact a left ventricle, because if we look at the septum, you can see that it's malaligned, and this region of the ventricular septum is actually very smooth and leading perhaps to finer trabeculations towards the apex. So this is the septal surface within the left ventricle. And as you can see, that's in a horizontal plane, whereas the atrial septum is in much more of a vertical plane. And if we then think about the conduction tissue, this malalignment has a severe impact on the position and location of the conduction axis. The normal AV node would be positioned here. There may be nodal tissue in this region, in fact, but it won't connect with the crest of the ventricular septum because of this malalignment gap that we're seeing here. So instead, we'd expect in this circumstance the AV node to be positioned antero-superiorly in this region, and then run superiorly around onto the ventricular septum, and then the branching bundles would follow the ventricles. So it's because of the malalignment that we have this abnormal position, an abnormal course of the conduction tissue in double inlet left ventricle. Now, in terms of development then, the AV junction has not expanded rightwards, it's remained over the left ventricle, but we've got division of the AV junction into two components, giving us two AV valves coming to this dominant chamber. And the defect that we were pointing out here, ventricular septal defect, is the remnant of the primary interventricular foramen, which is leading out to the morphologic right ventricle. Now, if we turn to a second heart, this one is analogous, but this has a common AV junction. So first of all, looking at this heart from the right side, if I can open up the right atrium, you can see here a very large atrioventricular septal defect. In fact, there is just a strand there separating the atrioventricular septal defect from a large atrial septal defect above. So very large atrioventricular septal defect. If we look at the ventricular chambers, again we have a rudimentary right ventricle, and which consists only of an apical component, again coarsely trabeculated, and an outlet component, but this time it's leading out, as you can see here, to the pulmonary trunk. So we have concordant arterial connections. But again, this is sitting on the shoulder, in fact on the right shoulder of a dominant left ventricular chamber. And again, you'll see the plane of the ventricular septum is almost horizontal, so I'm showing you on the screen, in contrast to the plane of the rudimentary atrial septum, which is more vertical. Now this, just going to show you from the other side before we talk about the conduction tissue. If we look at this from the other side, you'll see that we have a smoothly walled atrium there leading in to the common AV valve, which has these fine trabeculations, and then there is minimal straddling of the tension apparatus running over the defect there into the morphologic right ventricle. So the plane of the septum is here. Now that has an important consequence again for the location of the conduction tissue. It's analogous to the previous heart that we showed you with double inlet left ventricle, but it's very different to most examples of aviceptal defect with common AV junction. So typically in aviceptal defect with a common AV junction, we would expect the AV node to be displaced inferiorly and be positioned next to the mouth of the coronary sinus, so really down here. In this setting, because of the malalignment of the ventricular septum, so again, looking at this, the location of the plane of the ventricular septum, we would expect there to be an anterosuperior AV node. So again, if we open up the right atrium, we'd expect the AV node to be positioned here and then run onto the ventricular septum superiorly, and then the bundle branches to follow the ventricles. So that's a very different position to the normal position of the AV node we'd find in aviceptal defect. The final heart that I'm going to show you is an example of tricuspid atresia. And again, just to show you the morphology of the chambers, the ventricular chambers, before we look at the internal anatomy, looking at this heart from the outside, again, you'll see a rudimentary right ventricular chamber, which has an apical trabecula and an outlet component. And again, that's leading concordantly into the pulmonary trunk. The aorta is coming from the morphologic left ventricle. And that morphologic chamber, as we've seen in the other two examples, is sitting on the shoulder, on the right shoulder of the dominant left ventricular chamber. So let's have a look at that. If we look at this ventricle, you'll see that the AV valve, which is a mitral valve, there's an artificial tear in the anterior leaflet there, but the left AV valve is leading into this dominant, finely trabeculated left ventricle, which is then leading out to the aorta. This is the primary interventricular communication, which has actually begun to close in this example, and that's leading out into the rudimentary right ventricle there. So beginnings of closure of that primary interventricular foramen in postnatal life, I would say, but that's the remnant of that chamber. Now, in terms of conduction, it's much more difficult to say whether the AV node is superior or inferior, because we haven't got a right AV junction. We have an absent connection. The atrial septum has grown down and walled off the right side of the AV junction. So now we've got a completely muscular inferior floor to the right atrium. And the only outlet in this example is across the atrial septum into the left ventricle. And as you can see in this example, that's actually fairly restrictive, and the atrial septum itself is relatively muscular. So we can't say for sure where the position of the AV node is, but it's going to be in this region, and then it would pass in this region to reach the ventricular septum, and then of course the bundle branches would follow the crest of the ventricular septum.
So what Andrew has shown you now is the consequence of lack of expansion of the atrioventricular canal. And that left us with a situation in which the atrial chambers, the atrioventricular junction, was connected to the morphologically left ventricle. Now you all know that if growth is normal, then the atrioventricular canal will expand, and that will give the developing right ventricle its own inlet. And as part and parcel of normal development, The atrial septum will have grown down in normal fashion, and that will then have been reinforced by growth of the vestibular spine, providing the separate right and left atrioventricular junctions. So let's look at that with some pictures. So here we are, showing you the view of the reconstructed human embryo. Again, this is from one of the interactive PD files prepared by Wout Lammers, Jill Hicks-Boers, and we're looking at this at Carnegie stage 18. We're looking down on the atrioventricular junction from above, and again we see the atrioventricular canal myocardium in yellow. But what I hope you now see is that we can look down through the right side of the atrioventricular junction, and we're looking directly into the morphologically right ventricle, because there has been normal expansion of that atrioventricular junction. You'll also note that we're showing you fusion of the atrioventricular cushions, and that has separated the common atrioventricular junction into its right and left orifices. But then, purpley pink, you see the vestibular spine. And we're showing you that because the vestibular spine has reinforced the attachment of the atrial septum onto the atrial surface of those atrioventricular cushions, and it is that process that has given us the separate atrioventricular orifices. So that is what happens if there is normal expansion of the atrioventricular junction, giving the right ventricle its own inlet. But we need to stop for a little while, because that expansion is not always complete. So what is the consequence of incomplete expansion of the atrioventricular junction? And here we are back to malalignment, because when there is incomplete expansion, we will once more see malalignment between the developing atrial and the apical muscular ventricular septa. Of necessity now, the defect that will persist will open to the inlet of the right ventricle, because the expansion has been incomplete. But this can now occur following again the theme we are developing with either a common atrioventricular junction, or if that atrioventricular junction has been separated into its right and left parts, there will be straddling of the tricuspid valve, which is guarding that right part. So now let's look at what happens when we have incomplete expansion of the atrioventricular canal. Andrew is now going to show you this sequence, starting with common atrioventricular junction and then looking at straddling tricuspid valve.
Let me draw some analogies then with what Bob was just showing you on the embryonic data sets with some morphologic specimens. The first one I'm going to show you is of a common AV junction, which, as you will see, it goes exclusively, almost exclusively, to the left ventricle. But as you'll see, there is partial connection to the morphologic right ventricle. Let me just show you this specimen from the outside. First of all, here is the great arteries. This is the pulmonary artery, pulmonary trunk there, which is connected to the morphologic right ventricle. Now, if you look at the morphologic right ventricle in this case, you'll see that there is a partial inlet. So there is some inlet there coming into the RV and a papillary muscle supporting that AV valve. There's also an apical trabecular component and an outlet component. But as you'll see, as you'll appreciate, the morphologic RV is the rudimentary chamber, or it's the smaller chamber, let's say, the smaller ventricle, and the dominant ventricle is in fact the left side. So let me show you that. You'll see we're looking for the underside there of the common AV valve. These then are the two bridging leaflets, the superior bridging leaflet, which would be derived from the superior AV cushion that Bob was just showing you. Here's the inferior bridging leaflet derived from the inferior AV cushion. And what you can appreciate in this heart is that we've retained almost completely the connection of the atrial chambers with the dominant left ventricle. So there's been very little transfer of the AV junction, which is a left AV junction, to the right ventricle. And we saw a little bit of it just on this side. Now that has important consequences for the location of the conduction tissue, which is in a very different location to the previous example that I showed you. So I'm now showing you from the right atrium. As you see, the right atrium is quite dilated in this example. We can make out here the position of the coronary sinus, the triangle of Koch effectively. The normal position of the AV node would be here. But again, we've got malalignment between the plane of the ventricular septum and the plane of the atrial septum, but it's not going to be sufficient to give rise to a superior, anterosuperior AV node. So instead, in this instance, the way we would find the AV node would be to trace the ventricular septum inferiorly, so running inferiorly towards the AV junction, and then on the other side of the AV junction, the atrial myocardium, is where we'd expect to find the AV node. So a very different location to the anterosuperior AV node we just saw. This, if you like, is in the spectrum towards the previous example that I showed you with common AV junction. So that's the first example. We've retained the connection with the left ventricle. The second example I'm going to show you is an abnormal heart. I mean, it has discordant VA connections, but if I show you from the right side, open up the right atrium here, you can see here is the plane of the atrial septum. There is a relatively large ventricular septal defect, which is opening mainly to the outlet, but it is extending towards the inlet. And if we followed the crest of the ventricular septum downwards and see where it meets the atrial myocardium, you'll see it's almost in its anticipated position at the apex of the triangle of Koch, but in fact the ventricular septum is meeting the atrial myocardium a little bit more inferiorly than normal, and that would be the connection, the connection of the AV node to the ventricular septum, so the ventricular conduction tissue. Here's the remainder of the right ventricle. So we've got apical trabecular, we have an inlet, we have an outlet. But if I turn the heart over and show you from the other side, you will see that actually the AV connection is partly retained within the left ventricle. So what you're looking at from this side is the mitral valve, so leading into this relatively smoothly walled left ventricle. You certainly see a smooth septal surface here. But now adjacent to that, we've got caudal attachments and in fact papillary muscles coming across the septum and attaching to the free wall of the left ventricle. So during development, the AV junction has transferred to the right side, but it's still now partially connected to the left, and that's given us straddling tricuspid valve and also partial override of the orifice of the tricuspid valve, but with two separate AV junctions.
So now we've looked at incomplete expansion of the atrioventricular canal, and Andrew has shown you how that influences malalignment between the atrial septum and the crest of the muscular ventricular septum. But now we can take it a stage further, because not only can there be incomplete expansion, but as you see, there can also be excessive expansion of the atrioventricular canal. And then, because there is excessive expansion, the atrial septum will have been aligned with the apical muscular septum, so that will give us a regular atrioventricular conduction axis. The excessive expansion, however, means that the atrioventricular junction will now be opening exclusively to the right ventricle. But we're going to continue our theme, because this can be involved with a common atrioventricular valve, or with separate valves, or if the expansion does not quite go all the way, there can be straddling of the mitral valve through an outlet defect. And in extreme cases, the atrial septum can then wall off the left atrium, and that will give us mitral atresia. But because of the expansion of the atrioventricular junction, now the right atrium will be exclusively connected to the right ventricle. So let's now look at this sequence So Andrew is now going to show you the hearts that are going to show us the consequence of excessive expansion of the atrioventricular canal.
Let me illustrate the concept of excessive transfer of the AV junction to the right side using 3 specimens. Now, as it happens, all 3 specimens also have double outlet right ventricle. And you can see in this first one that the aorta is parallel to the pulmonary trunk and is slightly anterior and to the right of it, but we'll need to check the VA connections in just a moment. Let me turn the heart over and show you the AV connections first of all. Looking here at the right atrium, see the oval fossa defect, and then an AV valve which has effectively 3 leaflets leading into a coarsely trabeculated ventricle. So we have right atrium to morphologic right ventricle from this side. If we just check that arterial connection, you'll see that both great arteries are coming from the right ventricle. This is the aorta here, outlet septum dividing the aorta from the pulmonary trunk and the pulmonary outflow tract, which is coming behind. So we have double outlet right ventricle in addition. Showing you the other side, the other AV connection, here's the left atrial appendage, so finger-like left atrial appendage there, and you can see coming from the smooth left atrial myocardium, you can see a second AV valve, which again appears to have 3 leaflets, going again into that coarsely trabeculated right ventricle. And you'll appreciate that the trabeculations here are excessively heavy, and they almost divide this right ventricle into 2 components. You might be forgiven for thinking this is the ventricular septum. We know that it's not because similar hearts have been sectioned in the past, and this structure would not carry the ventricular conduction axis, so it wouldn't carry, in other words, the bundle branches on this structure. So where do we find the left ventricle, first of all? Well, if we turn the heart over, we'll see that there's a rudimentary left ventricular chamber on the diaphragmatic surface of the ventricular mass. And really, all there is left of the left ventricle is the smooth apical trabecular component. The inlet has transferred excessively to the right side, excessive transfer of the junction and division into 2 components, 2 valvular orifices, and the outlet, of course, we saw both the outlets coming from the right side. Now, just before we move on to the next sample, to show you the conduction axis in such a heart, it would the AV node would take a normal location, and the conduction axis would run normally onto that ventricular septum because there's normal alignment of structures. Now, the second heart I'm going to show you again has double outlet, has many similarities to the previous example. In fact, you'll see here we've got the pulmonary trunk, which is sitting to the left side of a smaller aorta, and both in fact are coming from the right ventricle. But let's look at the connections first of all. What you'll see in this example is that there's clearly an AV septal defect, a small AV septal defect there. The atrial septum has grown down to the AV junction, virtually to the AV junction at this point. There's some scooping of the ventricular septum, but fusion of the bridging leaflets to the crest of the septum. And the AV junction has transferred excessively to the right side and is now leading exclusively into the right ventricle. Now, before we show you the other side, just in terms of the conduction axis, this is quite interesting. It clearly wouldn't be a normal position of the conduction axis because we have an AV septal defect. So how do we find the location? Well, we trace the ventricular septum downwards inferiorly and see where it meets the atrial myocardium. So approximately here is where we'd find the AV node displaced inferiorly from its normal position and adjacent to the mouth of the coronary sinus. Now, if you think about it, that's very different to the previous heart that I showed you, where the AV junction was connected or remained over the left ventricle. Just looking at the outflow tracts then, here is the pulmonary trunk, and that's coming from the right ventricle. The aorta is also coming from the RV, but is the subaortic outflow tract is severely narrowed by this musculature. In fact, there's a complete subaortic infundibulum there, which is giving rise to the small aorta. So double outlet with subaortic stenosis. What about the left side? Really not much to see. The left atrium, as I said, is leading into that morphologic right ventricle, and really all there is remaining again of the left ventricle is this slit-like apical trabecular component. So if we just open that up again, you'll see there's a smooth endocardial surface there. There's no inlet and no outlet from this chamber because of that excessive transfer of the AV junction to the right side, and both great arteries remained over the morphologic right ventricle. Let's move to the final heart then. Slightly larger sample than the previous hearts, but again you'll see this abnormal arrangement of the great arteries just by chance. In fact, there is double outlet right ventricle. Again, the aorta is anterior and to the right of the pulmonary trunk. Let's look at the connections, the AV connections first of all. Here you can see from the right side, the right atrium here, we've got an oval fossa defect there, and you can see a tricuspid valve leading into this coarsely trabeculated morphologic right ventricle. If you look just behind the tricuspid valve, you'll see some additional tension apparatus coming into the same ventricle. So let's have a look at that from the other side. Turning it over, you'll see here that we've got a large left atrial appendage. We have a smooth left atrial endocardium there, and we have a mitral valve which has retained part of the connection with the left ventricle, but is also transferred across excessively into the right ventricle. But what you can see is that there's overriding of the mitral valve and straddling of tension apparatus into the right ventricle. So excessive transfer, but only partial excessive transfer into the morphologic right ventricle. Now, just to finish off, looking at the great arteries, here is the aorta, that's coming from the right ventricle, and the pulmonary trunk is more difficult to find, but it is in fact coming also behind there from the morphologic right ventricle. So double outlet right ventricle. And finally then the conduction tissue. Well, in this case the conduction axis would again be normal, so normal position of the AV node, then running down onto the crest of the ventricular septum.
So now let's return to normal development. Let's go to the stage at which there has been transfer of the atrioventricular canal, and as you have seen, that transfer will have provided the right ventricle with its own inlet. But at this stage during normal development, the outflow tract will still be supported by the developing right ventricle. So for the left ventricle, the outlet is the interventricular foramen, but now it is the secondary interventricular foramen. The key point at this stage during development is that the proximal outflow cushions are doing as the surgeon does, repairing double outlet right ventricle. Those proximal outflow cushions are muscularizing, and they are building a shelf so as connect the secondary interventricular foramen to one of the outflow tracts. The shelf, however, is exclusively within the right ventricle. So let's look at what happens during development. This is a picture of a murine heart, and it's at the same stage as the human heart I'm going to show you very shortly. You will appreciate, I hope, that you're looking into the right side of the heart. And there you see the right ventricular inlet. We have had normal expansion of the atrioventricular canal. But now look at the outlets. There is the pulmonary route, and there is the aortic route. They are both arising above the developing right ventricle. But what we can also see there are the proximal parts of the outflow cushions, and you see that as yet they have not come fully together. The embryo is fusing these outflow cushions to build a shelf in the roof of this right ventricle. But if we look at the back of the right ventricle, there we see the channel between the ventricles, and it is providing the outlet from the left ventricle. It is the secondary interventricular foramen. So this is what it looks like in the mouse heart. Let's look at what it looks like in the human heart. So now I'm back to one of the interactive PD files prepared by Wout Lammers and John Hicks-Boers. I'm showing you only here the right ventricular aspect of the developing right ventricle and the two outflow tracts. So in yellow again, you will remember we see the atrioventricular canal myocardium that has expanded to give the right ventricle its own inlet. And the inlet is now guarded by the developing tricuspid valve. There you're looking at the right ventricular aspect of the muscular ventricular septum. And we've also reconstructed the interpericardial arterial trunks supported by the arterial roots. And both of the arterial roots are supported by the developing right ventricle. So the only way out of the left ventricle is through the secondary interventricular foramen. Now, I've not shown you at this stage those proximal outflow cushions, but I can do that by taking us one step further, where I have also put in place those muscularizing outflow cushions. And there you see them. You can see that they are fusing together. They are building a shelf in the roof of the right ventricle so as to commit the subaortic outflow tract to the left ventricle, providing the left ventricle with its own outlet. If development proceeds normally, those proximal outflow cushions will then remodel and they will form the subpulmonary infundibulum as the membranous septum closes the tertiary interventricular foramen. But if transfer is incomplete or is excessive, then those cushions can persist as an outlet septum. The outlet septum can be muscular if those cushions muscularize. It can be fibrous. And now we come to malalignment, because the septum can be malaligned, and it can be malaligned cranially, or it can be malaligned caudally. And this is the consequence of cranial malalignment of this outlet septum. Because I'm showing you here the outlet septum that has been cut out from a specimen that has tetralogy of Fallot. So there you're looking at the aortic valve, which is on the back of this muscularized mass that forms the outlet septum. There is the pulmonary valve, and now you see a tissue plane that has developed between that muscularized cushion mass and the aortic root. Part of that is now a right ventricular outlet septum, whilst the other part has become the muscular subpulmonary infundibulum, but that is malaligned and it is producing obstruction to the subpulmonary outlet. If the outlet septum is malaligned in cranial fashion, there will be overriding of the caudal outflow tract, and usually that is the aortic root. And that is the essence of tetralogy, in which there is also subpulmonary obstruction, but we can also have that in the so-called Eisenmenger defect when there is an unobstructed subpulmonary outlet. Then the ventricular septal defect is the tertiary interventricular foramen. It can be membranous or it can have a muscular postero-inferior rim. So now we're going to look at some specimens showing you these features of cranial malalignment of the muscular outlet septum.
The first specimen I'm going to show you then is an example of tetralogy of Fallot, as Bob has already intimated, and you'll appreciate that the pulmonary trunk there is much smaller, about a quarter the size of the aorta. The outflow tracts are crossing each other, as you'd see on imaging, but undoubtedly the pulmonary trunk and the pulmonary outflow tract, as you'll see, is much smaller than the aorta. Now, if we look at the anatomy from the morphologic right ventricle, you can see the coarse apical trabeculations of the right ventricle here. You can see that there is, if we look at the borders of this defect, you can see that it is in fact a perimembranous ventricular septal defect. So it's running back onto the tricuspid valve. In fact, there is tricuspid to mitral fibrous continuity in the inferior border of the defect. There is also tricuspid to aortic continuity. But you'll see there is malalignment of the structures that are formed below the level of the arterial valves, as Bob has just been describing to you. So the structure in particular that I want to point out is this structure. This is the muscular outlet septum. And as you can see, it has 2 points of attachment. One at the ventricular septum, in fact, is attached to the anterior limb of this structure, which is the septomarginal trabeculation, or otherwise known as the septal band, and a parietal attachment to the free wall of the right ventricle. So this is an abnormal structure. In the normal heart, it is minuscule. As Bob has described, it normally forms a shelf which will wall off the aorta from the right ventricle. But in this example, as you'll see, it's malaligned with respect to the plane of the ventricular septum, which is in the plane of the screen. It's swung around from that position and now is malaligned, and of course is contributing, and the main contributor of obstruction to the right ventricular outflow tract, as we would find in tetralogy of Fallot. In fact, if you look at this, you see that we have the subpulmonary infundibulum running down, and then overlying the muscular subpulmonary infundibulum, we've got this fibrous tissue. So in fact, there's almost a ring of fibrous tissue there at the opening, at the mouth of the subpulmonary infundibulum. But this is a perimembranous defect. It is a perimembranous and outlet defect because it's opening above the orifice of the tricuspid valve, and it's associated then as a third aspect with malalignment of the outlet septum into the right ventricular outflow tract. Now, as Bob has intimated, there are variations to the defect in tetralogy of Fallot. So here's a second example, and again, if we look at this from the outflow tract, you'll see that there's a small pulmonary trunk with respect to the aorta. It's probably half the size or a third the size of the aorta. Again, we've got crossing outflow tract, so you'd find that on imaging. When we look at the ventricular septal defect, you'll see that again, it is an outlet defect. It is opening above the annulus of the tricuspid valve, above, if you like, the septal anterior commissure. This is the anterior superior leaflet there. There is override of the aortic valve, as we saw in the previous example, and as we would expect with tetralogy of Fallot. But in this example, although it's an outlet defect, the inferior floor of the defect is now muscular. And the reason for that is that the inferior limb of the septomarginal trabeculation is large enough to have met the free wall of the right ventricle, and that therefore is overlying the path of the conduction tissue, which would be below this muscular rim. And so the conduction tissue in this case is relatively protected by this inferior muscular rim, whereas in the previous example, perimembranous defect, it would have been exposed in the floor of the defect. So that is a muscular outlet defect. We know it's muscular outlet because we look at the borders from the right ventricle. You can see it has completely muscular margins, and it's within the outlet component of the right ventricle, associated again with this narrowing of the right ventricular outflow tract. And again, in this example, you can see a fibrous buildup, so fibrous tissue there, overlying the muscular subpulmonary infundibulum. The pulmonary valve is attached at this point, and as you can see here on the other side, the aortic valve is attached slightly lower, and that's because, in part of the subpulmonary infundibulum, and because of the abnormal malalignment of the outlet septum. Now, there's some artificial cuts in the outlet septum here, but you can certainly see that it's an abnormal structure. It's rotated out of the plane of the screen and into the right ventricular outflow tract, giving the anatomy of tetralogy of Fallot. So this is quite a long outlet septum associated with a muscular defect. The final example that I'm going to show you then is a slightly more complicated example. I'll zoom in slightly to show you this from the right ventricular side. Again, same view as the previous examples. We'd have to classify this as an outlet defect. As you can see, it's opening above the annulus of the tricuspid valve. This is the anterior leaflet and superior leaflet, and the septal leaflet here. So the anteroseptal commissure is the key marker there. But this is both perimembranous and also juxta-arterial. And the reason we say that is if we look at the inferior border of this defect, it is formed of fibrous continuity between the tricuspid and the mitral valves. Whereas the upper border, so if you like the roof of the defect, is formed of fibrous continuity between the aortic valve on this side and the pulmonary valve on this side. But why am I showing you in this section? Well, there is again malalignment between the remnant of the outlet septum, so this fibrous strand which has failed to muscularize from those fusing proximal outflow tract cushions, just failed to muscularize, and it's remained as a fibrous cord there separating the pulmonary valve from the aortic valve. But that fibrous strand is also malaligned with respect to the plane of the screen. So again, it's rotated out of the plane of the board, and it is obstructing, potentially obstructing the subpulmonary outflow tract. To show you one final specimen which shows malalignment of those structures, again with some override of the aortic valve, but without obstruction to the pulmonary outflow tract. Bob has just described how the proximal, fusing proximal outflow tract cushions will normally wall off the aorta from the right ventricle. In this case, there is a degree of malalignment between the outlet septum, which is this structure, separating the aortic valve from the pulmonary valve on this side. So you can see that in fact, if we rotate it round, this would fit within that defect, and then we'd have normal outflow tracts. But there is a degree of malalignment. It's perhaps not severe, quite as severe as the previous examples that I've shown you. However, in this setting, in this particular heart, there is no obstruction to the pulmonary outflow tract. So if you look at the pulmonary valve here, you'll see that it's normal size. The leaflets are normally formed, so 3 leaflets to the pulmonary valve. There is a wide subpulmonary outflow tract, so pulmonary infundibulum has formed correctly. And as a consequence of that, you will notice the Eisenmenger, consequences of Eisenmenger physiology in this heart, pulmonary vascular disease, leading to high resistance to the right ventricle and hypertrophy of the right ventricular myocardium. My probe is about 1 millimeter in thickness, and the right ventricle should be approximately 1 to 2 millimeters. And as you can see in this example, this is half a centimeter in thickness or more. So one form of Eisenmenger physiology with malalignment of an abnormally formed outlet septum, which, as we said, in the normal heart is a rudimentary structure, not giving rise to pulmonary outflow tract obstruction, but clearly giving rise to very abnormal physiology.
So Andrew has just shown you the consequence of cranial malalignment of the outlet septum, and he's emphasized to you that as part and parcel of that cranial malalignment, there is overriding of the caudal outflow tract. And what you've seen in those specimens is that usually that caudal outflow tract is the subaortic outflow tract. And we can give you an impression of what is happening to the transfer of that outflow tract if we look at the murine heart again. Remember, this is normal development, so it's not exactly the same, but it shows you the consequence of that transfer of the caudal outflow tract into the left ventricle. We're seeing the situation just prior to closure of the tertiary interventricular communication. So, there we have the aortic root, and I hope you can see that that is overriding the crest of the muscular ventricular septum. And this shows you now exquisitely the difference between the secondary and the tertiary interventricular foramens. Because there is the secondary foramen. And as you see, it is becoming aligned so that it will become the outflow tract for the morphologically left ventricle. But you'll see that there is a remaining communication between the aortic root and the right ventricle, and that is the tertiary interventricular communication. And that is the space that is eventually closed by formation of the membranous septum. Now, the heart you've just been looking at had cranial malalignment of the outlet septum. And because of that cranial malalignment, the membranous septum is never able to close that tertiary interventricular communication. But we're going to finish the session today on malalignment to show you the other aspect of malalignment of the outlet septum. Because if the transfer of that caudal outlet is excessive, then whether the outlet septum is muscular or fibrous, it will be carried excessively into the left ventricle. And then it will obstruct the secondary interventricular foramen. As I've just shown you, that secondary interventricular foramen is the left ventricular outflow tract. And if we have obstruction of that secondary interventricular communication when the ventricular-arterial connections are concordant, we will obviously have some aortic obstruction, but should the ventricular-arterial connections be discordant, then the obstruction will be subpulmonary, and that, of course, is what you see with transposition. So now, to complete our discussions on malalignment, Andrew is going to show you the consequence of caudal malalignment of the outlet septum.
This first example I'm going to show you is an example, actually, as you see, it's had surgical repair of interruption of the aortic arch. And in fact, you can see there is a interposition graft there being inserted between the ascending aorta and the descending aorta. You can see the pulmonary trunk is running over the top of the aortic outflow tract, so the arteries are crossing, the outflow tracts are crossing each other in the usual manner. You can see a small right ventriculotomy within here. And then if we look inside the heart, you will see that there is a defect. And let's have a look first of all at the borders of that defect. If we look at the inferior border of the defect, you can see that that is perimembranous. It's running back onto the commissure between the anterior and the septal leaflet of the tricuspid valve. And therefore the majority of this defect is opening to the outlet of the right ventricle, but it is also perimembranous. So perimembranous outlet defect. If we look at the superior border of the defect, you can just begin to appreciate from this view that the outlet septum, so the structure separating the arterial valves, the pulmonary valve from the aortic valve on the other side, is pushed back into the screen, so it's deviated into the left ventricle, deviated caudally into the left ventricle. Let's have a look at the effect of that from the left side of the heart. So if you look at the left ventricle, you can see normal formation of the mitral valve, perhaps a little bit of a narrower left ventricle, but certainly you see nice smooth and fine apical trabeculation, so smooth septal surface, some cuts within the ventricular septum there. And then looking up towards the outflow here, looking towards the aortic valve, you can see here's the ventricular septal defect. There is the fibrous continuity between the mitral and the tricuspid valve, and therefore we know the conduction axis will be exposed inferiorly. But if you look at the superior margin of the defect, you'll see that actually the outlet septum, both muscular and this fibrous component on the left side, is deviated caudally, so deviated, if you like, posteriorly into the left ventricle, and that is giving rise to narrowing of the sub-aortic outflow tract. And that, as we saw, has been associated, and is associated in this case, with interruption of the aortic arch, which has been repaired. If we look at the aortic valve, you'll see that it has one leaflet there, but there is fusion between these two leaflets. So we have a bi-leaflet pulmonary valve, which again is a common association with this form of malalignment of the outlet septum and with interruption of the aortic arch. Let me move to a second sample. I'm just going to zoom out a little bit as I move to this sample, because as you see, it's a pediatric specimen. Again, there is interruption of the aortic arch. You can see that the arch, the ascending aorta, branches into two vessels. The first is the brachiocephalic artery. The second is the left common carotid artery. And in fact, you can see here is the left subclavian artery, which appears to be arising anomalously from the arterial duct. But in fact, of course, there is interruption between the left common carotid and left subclavian artery. So in fact, here in this example, you'll see that the arterial duct has completely closed off, and this is then connecting the descending aorta only to the left subclavian artery. The pulmonary outflow tract again is crossing over the aorta. The aorta is smaller, ascending aorta is smaller than the pulmonary trunk, as is often the case. Looking at the defect from this side, so from the right ventricular aspect, you can see here that again it's a perimembranous defect. It's running back onto the tricuspid mitral fibrous continuity, and therefore the conduction axis will be exposed within the inferior margin of the defect. So it's perimembranous, and it's also opening again mainly to the outlet of the right ventricle. We turn the heart over and show you the outflow tract. In this case, the left ventricular outflow tract. We look up towards the aorta. You'll see there is a degree of malalignment there between the outlet septum, which is this structure, and the crest of the ventricular septum. If I just focus in on that slightly more, you will see that in this case, the outlet septum is essentially a fibrous cord. There really isn't much muscular component here, so we can assume that the proximal part of the outflow tract cushions below level of the forming arterial valves hadn't formed properly. That's left us with this fibrous raphe, fibrous cord there, separating and deviated into the subaortic outflow tract. So there is some rotation of this structure with respect to the crest of the ventricular septum, and again that can lead to some narrowing of the subaortic outflow tract. Now in this particular example, you can see that there are in fact two leaflets of the aortic valve. So again, this is a bileaflet aortic valve, and there's a raphe there, a fusion point between two of the leaflets of the aortic valve, as we saw in the previous example.
So we've shown you a lot of specimens in this session. We've tried to link that with development. We've tried to show you that malalignment can not only be found with separate junctions, it can also be found in the setting of a common atrioventricular junction. And we've linked that with double inlet ventricles. We've shown you it can be found either when those defects open to the inlet or the outlet of the right ventricle, so the geography of the defect is important. But what we've tried to emphasize also, and you've seen that most beautifully with the demonstrations that Andrew has shown you regarding the conduction system, is that it is the phenotype dictated by the borders that give you that crucial information. So borders are important, geography is important. Malalignment itself is not a phenotypic feature in isolation, but when it is present, it needs to be described. And that is our take-home message. And now, to reinforce all of that, we're going to ask Justin if he would share with us some of the images he's prepared using computerized tomographic data sets.
I'm going to review 3 different patient computed tomographic data sets, each with a different form of an isolated perimembranous ventriculoseptal defect with septal malalignment. And I'm going to compare them to images from this excellent paper that I would highly recommend, where we evaluated over 350 heart specimens with different forms of perimembranous ventriculoseptal defects, of which both Professor Anderson, Professor...
Sorry, wait a moment.
Cook and Diane Spicer were involved in the study. So in this first example, this is an adult patient. And this patient had palliation with a lateral.
You can't see the picture.
Yes, it's coming. Wait a moment. Sorry.
I'm going to review 3 different patient computed tomographic data sets, each with a different form of an isolated perimembranous ventriculoseptal defect with septal malalignment. And I'm going to compare them to images from this excellent paper that I would highly recommend, where we evaluated over 350 heart specimens with different forms of perimembranous ventriculoseptal defects, of which both Professor Anderson, Professor Cook, and Diane Spicer were involved in the study. So in this first example, this is an adult patient, and this patient had palliation with a lateral tunnel Fontan. So as we cut into a 4-chamber view, we can see the lateral tunnel Fontan positioned posteriorly. We can also appreciate that the primary atrial septum has been resected during these palliative procedures, only leaving the interatrial infoldings, which we can see posteriorly here with epicardial fat within. This is the right atrium. This is the left atrium with the pulmonary veins coming in. The mitral valve was oversewn. We can see the tricuspid valve with the right ventricle and the left ventricle. And there's a large perimembranous ventriculoseptal defect. And I can say that because it goes right up to the anterior aspect here of the tricuspid valve and where the mitral valve would be. So that leaving this fibrous continuity between the AV junctions. And we can also appreciate when we look at this posterior infolding, if we imagine where the primary atrial septum would be, or oval fossa, it would be malaligned relative to the crest of the ventricular septum. There also is clearly override of the tricuspid valve with straddling of its cords attaching over into the left ventricle, which precluded septation of this ventriculoseptal defect, leading to the decision for Fontan palliation. And so if we rotate, looking over from the left ventricular aspect, just to appreciate this large perimembranous defect, which is extending into the inlet. So geographically, it's opening into the inlet of the right ventricle. From a border standpoint, because of that fibrous tissue between the mitral to tricuspid valve, it's defined as a perimembranous defect. And then we'll rotate over into a right anterior oblique view. So this is the right atrium. It's a little dark here, but we can see that coronary sinus in the background. And then here's the tricuspid valve. This is the tripartite right ventricle with its inlet, apical trabecular, and outlet component with the tricuspid valve seen here. And we can compare it to this analogous image over here of a heart specimen cut in a similar view, where we're viewing this intact atrial septum there with the coronary sinus, the septal leaflet hinge line of the tricuspid valve, and we can compare the plane of the oval fossa to the plane of the crest of the ventricular septum, which is malaligned towards us. So there's malalignment between the atrial and the ventricular septum as seen here. And with a very large perimembranous inlet VSD, inlet because it's opening into the inlet of the right ventricle, with malalignment between the ventricular septum and where we could imagine where that atrial septum would have been prior to its resection. And so, as Professor Cook had mentioned related to the conduction axis, then we can expect that the AV node, instead of being at the apex of the triangle of Koch, right here we can see, again, dark, but we can see the tendon of Tadaro there, the eustachian ridge leading up to this point here, where the membranous septum would be, and then the septal leaflet hinge line. So that's where normally the AV node would be. But with this malalignment between the atrial and ventricular septum, we can expect that the AV node will anomalously be positioned more posteriorly near the mouth of the coronary sinus, and the penetrating bundle will then penetrate The axis will course with a long relationship and close relationship around the posterior inferior margin of this perimembranous inlet VSD. Up here to there we see the medial papillary muscle where the right bundle branch would then go down the septomarginal trabeculation. So a high risk for conduction damage related to this anomalous position with a very long and close relationship course of this atrioventricular conduction axis. And then if we rotate into, and there's just removing the tricuspid valve to appreciate the extent of this large perimembranous inlet VSD. And then we can rotate into a short axis of the AV valves. Again, that mitral valve is oversewn. There's a aortic root wedged in between the AV valves, and here's the tricuspid valve. And right in between the leaflets, we see that malaligned crest of the ventricular septum, which is malaligned anteriorly relative to where the atrial septum would be. And it's residing right around 50% within the orifice of the tricuspid valve. So once that tricuspid valve overrides more than 50%, we would change this diagnosis to calling it double inlet left ventricle, with both the tricuspid valve and mitral valve primarily draining into the left ventricle. So this next example is a patient with also with a perimembranous inlet VSD. This is a young neonate who had severe aortic coarctation, a bicuspid aortic valve, who underwent a CT to define the aortic coarctation. So here I'm cutting into a 3-chamber view showing the left atrium, the mitral valve, the left ventricle, the left ventricular outflow tract, and the aortic root and ascending aorta. And we can see this relatively smaller VSD, the perimembranous VSD, which is located right under the aortic valve, with the outlet septum, which is deviated towards us. Deviated, we can see right down here, this directional block showing that it's deviated posteriorly towards us. So there's posterior deviation of the outlet septum. And if we compare it to this top panel, which is looking in a similar plane, at the left ventricle here, we see the tricuspid valve tissue, which is contiguous with the remaining central fibrous body, which is formed by the membranous flap, which is running into the mitral valve. So through the means of the remaining central fibrous body, there's fibrous continuity between the tricuspid to mitral valve, which we defined in a study as present 100% of the time in perimembranous VSDs. Historically, it was thought to be tricuspid to aortic fibrous continuity. However, we showed that in these type of defects, especially the perimembranous outlet defect, when there's malalignment, we can have discontinuity between the aortic to tricuspid valve. And that's present in this heart, where there's this muscular bar from the outlet septum deviated posteriorly, which is not allowing fibrous continuity between the tricuspid to aortic valve. So there is not fibrous continuity between the aortic and tricuspid valve. However, there is between the tricuspid and mitral valve. As said, that's 100% of the time in perimembranous defects. So this is, from a border standpoint, perimembranous. And so we can appreciate that same anatomy here with, albeit a smaller ventricular septal defect, that outlet septum is deviated posteriorly. And this right there would represent that membranous flap, the atrial ventricular portion of the membranous septum, which remains intact, part of that central fibrous body, which is in fibrous continuity. Here is the infraseptal recess, which is a fibrous structure leading into the right fibrous trigoon related to the mitral valve. So fibrous continuity between that structure, between the tricuspid to mitral valve, while discontinuous fibrous or no fibrous continuity between the aortic to tricuspid valve. And then if we cut this, here I'm just showing closer and giving you a sense of that very slight posterior malalignment of the outlet septum. And then we'll change into a short axis view. And then the same thing as we cut down from the aortic root down into the virtual basal ring plane. Again, very slight, but here's that outlet septum, which is deviated ever so slightly posteriorly into the left ventricular outflow tract relative to the crest of the muscular septum here. and then looking in a right anterior oblique view, and we can see that that VSD is positioned relatively centrally, and that's where there tends to be more of a gray zone when defining the geography of the defect, because here's the septal leaflet of the tricuspid valve. One could argue that this only opens centrally. It does extend ever so slightly towards the outlet here, and we saw from the other views that it does open here into the outlet of the right ventricle. And then that outlet septum deviated posteriorly, so into the screen here, into the left ventricular outflow tract. But we can see the septal marginal trabeculation with its anterior cephalad, and then its posterior caudal limb, again with very slight extension of this defect from that central area anteriorly into the outflow of the right ventricular outflow, or of the right ventricle. So and we can compare it here to this specimen here. Again, a much larger defect, which very clearly extends in the outlet, but hard to tell the outlet septum from this position and the right ventricular aspect unless we look over at the left ventricle to see that it's posteriorly deviated under the aortic valve. And then lastly, this is a CT data set that we had looked at in the last session. This is an infant with tetralogy of flow. And so we're looking in a right anterior oblique view, the right atrium, the right ventricle, its inlet, apical trabecular and outlet portion. We see the septal marginal trabeculation with its anterior cephalad and posterior caudal limb. There is the medial papillary muscle with attachment from the tricuspid valve leaflets with this very large ventricular septal defect, which is clearly in the opening to the outlet of the right ventricle from a geographical standpoint. We can also see the outlet septum here, which is deviated anteriorly into the right ventricular outflow tract, causing right ventricular outflow tract obstruction. And then if we dissect into the tricuspid valve leaflets, we can then see that there is in fact fibrous continuity here between the tricuspid valve into the aortic valve leaflet and over into the mitral valve, where this posterior caudal limb becomes deficient more posteriorly behind its insertion of the medial papillary muscle. So from a borders standpoint, it is perimembranous, which tells us that the conduction axis will run along the posterior inferior margin of the defect. So very important information for the surgeon. And if we compare that to this analogous specimen image, then we see that the outlet septum is deviated anteriorly into the right ventricular outflow tract. However, in contrast to the CT data set, the specimen shows that the right ventricular outflow tract is wide open. The infundibulum is well formed. There is no right ventricular outflow tract obstruction. So this would not be tetralogy of flow, but it would be the most common defect, the perimembranous ventriculoseptal defect with anterior malalignment of the outlet septum with a well-formed infundibulum with no outflow tract obstruction, or the so-called Eisenmenger defect. If we come back over to the CT data set and we'll cut it into a short axis, and I'm going to just bring it back so you can pay attention to that outlet septum as I rotate it, and just pay attention to that outlet septum as we rotate it around into the short axis of the aortic root and cut back down into the outlet septum. So that's that structure here. It's anteriorly deviated into the right ventricular outflow tract. The defect is here opening into the outlet of the right ventricle. And as we cut down, then you can see how the defect, its posterior margin extends right up to the septal leaflet of the tricuspid valve, allowing that fibrous continuity between the mitral and tricuspid valve, along with the tricuspid up into the aortic valve, into the screen towards us.
Well, thank you, Justin. Thank you, Sasha. Those were spectacular images that we just saw there, Justin, and the comparisons you've just made with the images we made for our paper in the Orphanet journal are superb. Sasha, is Norman and Adrian with us? Adrian, are you with us?
Yes, Adrian is here. Hi, Adrian. Welcome.
Hi, I'm here too.
And Norman is here. Perfect.
Adrian, do you have any comments to make?
I have a bit too many, so I'll let Norman start first.
Norman.
mean, I would say that it's the same and concede to you, but the one thing that, firstly, this was a very dense presentation today. Andrew presented us with such a huge amount of data that it was often difficult to assume it all in one go. And of course, that's the reason we have a recording, so that you can go back and study these things again. And thanks to the Congenital Heart Academy for that. The one thing that interested me is always that when there has to be an atrioventricular conduction, then there's malalignment. You have to look where the ventricular septum and the atrial septum join in the mass. And I think that that's point, Bob, that you've emphasized in the past, and perhaps you could articulate that again for us. But to me, that's the most important thing when looking at a specimen, to decide, and also for the surgeons, of course, to decide where the conducting tissue is running.
Absolutely.
And
I mean, you've hit the nail on the head there. And I think that what Justin showed us so beautifully today is that now, using the interactive CT data sets, you can show precisely that. I think the picture he showed us of that straddling tricuspid valve was quite spectacular. And what we tried, and I agree with you also, that it was a dense presentation. We did have a lot to show. I think that if people take the time, as you also intimated, to go through it again and again, the message is going to come through, because you hit the nail on the head. It's the malalignment between the atrial septum and the ventricular septum that is the key. And what we tried to emphasize today is that you can get that either with separate atrioventricular junctions, so a straddling tricuspid valve, but you can get exactly the same thing with atrioventricular septal defect and left ventricular dominance. And I think Justin showed that particularly beautifully. And I think, Justin, you would be able to show exactly that also now if you were doing CT data sets, would you? If you had CT data sets of patients with AVSD.
Yes, yep, we could definitely show that. I think the question comes clinically, as I showed that first case was a patient who had a Fontan palliation. The second case was a patient who additionally had aortic coarctation. So the CTs were not obtained to define the VSDs, since we certainly can define this kind of detail with two-dimensional echo in terms of what the phenotype is of the defect and so on. So I'm not sure that it's always clinically indicated, but we certainly can look at this detail when CT is obtained.
And you think, Justin, that Norman can probably also answer to this. Can you see the malalignment with the same degree of accuracy using echo as you can showing it so exquisitely with the CT data sets?
well, I think we can, Bob, and you've seen our app, which has several of these beautiful echomorphological correlations of this malalignment. I think that it certainly is shown in my experience. I don't know that having looked at all of Andrew's specimens, if I'd encountered some of those rare ones, whether I would have been able to make that issue. But I think that we can understand the plane of the septums, both atrial and ventricular septums, quite easily with echocardiography. And certainly it would bring this into account for consideration of further investigative tools. I hope that answers your question, Bob.
Yeah, indeed. Justin, you're also echocardiographer and a CT man. Would you agree with Norman there?
Yes, yeah, I absolutely agree. I think the purpose of these sessions aren't to suggest necessarily what the diagnostic approach should be. It's just to try to show with living data sets the anatomy. But as I mentioned before, echo is certainly the mainstay. That said, we certainly here at the Cleveland Clinic, more and more, we have some of the better scanners, dual source scanners that are very quick temporal resolution. We can get very nice scans with very minimal radiation. I'm surprised every time we do these scans on these young babies, The techs the babies will be crying. The techs will tell me, oh, it's okay. We'll get the scan because it's so quick. The radiation is so minimal now with these newer scanners. So I think we're learning here. We certainly have a lower threshold with specific clinical questions, but to define a VSD, it certainly is echo.
I mean, to me, as an anatomist, the exquisite features of those CT data sets. I mean, as you showed, I was amazed as you showed them. And I looked at the comparison you were making with the pictures that Diane had taken of those hearts. And you could almost see that they were like and like. So to me, as an anatomist, the images, with the best will in the world for Norman, who produces quite magnificent echocardiograms. But I think, Norman, even you would agree that the correlation that Justin made is a little better than we've managed in the app.
Oh, I think that's true. I mean, but I think that's not the argument over here, as Justin had mentioned. I think, Bob, there's one other point that I want to make, maybe two. The first is that I think that we have to remember that the AV node is not a single structure that develops, but that the AV node develops from a condensation of a ring of conducting tissue that occurs around the right atrioventricular junction. And so it's not like that the AV node is moving around. It's that the AV node develops from a particular form of tissue. And we've seen this, for example, in the Monkeyberg spring that Andrew and I had some experience with some of his previous three-dimensional data sets. So I think that that's something that maybe the participants need to remember, is that the AV node is not a isolated developmental structure, but that it develops from a ring of tissue. And the last point.
No, that's a very good point you make there. And you commented that it develops relative to the AV canal, but it also develops relative to the primary interventricular foramen. And that brings us back to the point we were trying to emphasize today. Everything has to do with the expansion of the primary interventricular foramen. And that is why, on occasion, it doesn't reach the base of the atrial septum, because you don't get proper transfer. So it's another very good point you make, because the AV node is not only related to the atrioventricular canal, it's also related to the ventricular septum, as it ought to be, through the interventricular ring around the primary interventricular foramen. But a very good point.
So, and last point, Bob, which is just really, maybe it's not a comment for the audience, but I think that the next time that you are thinking about doing sessions of making new data, that perhaps if you would draw on your embryological data sets, the conducting tissue as it develops, I think that would be very helpful for the viewers, because it's complicated. And I think that would be a great session to have conducting tissue superimposed upon the murine, the human, and the llamas data sets.
In fact, I don't know whether you ever tried to access the interactive PD files that are available now that Lamas and Hickspoor have produced, but in fact, you can find the primary interventricular ring in their data sets. And I thought of doing exactly what you have suggested, of trying to put that in to some of the reconstructions. And it's a very good point you make, and we will try to do that. In fact, on the next session, Diane and I are going to be discussing the specific types of isolated defects, the muscular ones, the perimembranous ones, the doubly committed ones. And there we'll try and make the point you have just focused on, try and put in the conduction system again. And we're going to ask Justin to replicate that again with the CT data sets. So that is what we'll do in our next one, which we hope will be broadcast in October. So we'll try and do what you suggest. You're muted, Norm. You're muted.
Andrew associated with Tal Gaver in a series of MRI data, and there's a way of processing the conducting tissue in MRI that allows this to be seen. And he's really got some quite spectacular images published in Circulation, I think, about a year or two ago, that are really quite remarkable.
It's the MR data, the visualization of the conduction system is not entirely 100%. So I'd be a little dubious of some of that. But Justin, you were involved with that to an extent, were you not?
Yeah, I mean, our work is continuing to try to understand the conduction system, and initially the goal was to image it. We're very familiar with the different works out there to do that clinically, and I think a lot of it still leaves a lot to the imagination. But that certainly is the holy grail, as Professor Anderson would say, to be able to image the conduction system.
I mean, to me, at the moment, I think we can get a better indication of where the conduction system is likely to be by what we know already, and simply demonstrating the relationships between, as Norman has suggested, the atrial septum, the ventricular septum, looking at malalignment. And I think that gives us a better indication, but I admit to my bias in that respect.
Right, and that's where our focus has drawn towards, given the I think, and too bad Andrew Cook is not here, the most convincing data is synchrotron radiation, which you're not going to do on a patient.
Absolutely. And in fact, I've been involved with synchrotron data with a Japanese group as well. We published that 3 or 4 years ago in Journal of Thoracic and Cardiovascular Surgery. But you make the very good point, we can only do that on dead hearts, but at least we can show what's going on.
And I would add, our attention has turned to what can we see visually, whether by imaging or the surgeon intraoperatively, that can guide where the conduction axis is going to be. And we have some works that are under review and so on. But with some of this work, when I see like some of the staining, intraoperative staining techniques, to me, we're doing a lot with histology, and it's difficult even with well-stained histology to follow the smaller components of the conduction axis. And when I see these intraoperative images that it looks like unstained histology, I think it's very challenging to be accurate.
Adrian, do you have any comments?
Thank you. It's been a very difficult session, as Norman said, and I think this session in particular links a lot to embryology and to what happened between the two primordial orifices of the AV canal, the primary interventricular communication and the outflow, because all that area that is in your very first image, it looks like a very large area of the inner heart curvature, what is basically. What happens to that in order to have the expansion of the canal, it's still that, I think that's the crux of the problem, to understand this. And for the symmetry of the discussion, I'm not sure whether we should have included double outlet atrium and common arterial trunk and discuss about the common ventricular arterial junction and what happens in these entities, just for the symmetry.
Well, I mean, as you know, we've already been going today an hour and a half.
I know.
And
I know.
Norman has commented, you have commented, it was dense. I mean, that is something that what you say is true, but that is something we need to, I think that is another topic that we can move forward to in next year, and to bring up again what we've been doing today. I think we've been emphasizing in the previous session, this session, the expansion of the AV canal. It's a concept that I think we need to work on, but you are correct. I mean, there's been another very interesting question that came up, and someone has said, how can it be if, as I suggested, the atrial septum is malaligned during development, so you have absent right or absent left connection, how is it that then the valve that develops becomes a mitral valve or a tricuspid valve rather than a common valve? And I think that is all to do with the fact that once the atrial septum has malaligned in such a way, the orifice no longer is common. It becomes either a left atrioventricular orifice or a right atrioventricular orifice, and the embryo then develops the valve because it knows then it's either a right or a left atrioventricular orifice. So we have a tricuspid valve or we have a mitral valve. But these are all things that, as you say, we need to put into the context also of double outlet atrium, common arterial trunk. But that's another story again.
Yeah, and on one of your images again, when we talk about the fusion of the cushions does not make a junction.
Correct.
This is something very important. And in one of your images, the cushions are mostly into the left orifice,
Correct.
not to the right.
Oh,
So
you are right there. And it's the addition to the fused cushions of the vestibular spine that divides the orifices.
And that leads to the discussion of who is malaligned versus what it's actually malaligned versus what. But I don't think in tricuspid atresia, the interatrial septum actually is oblique or malaligned, because I also noticed you avoided the term of crux cordis, which I thought you would have used but I know you have recently gone away from it.
But I think the point you make, I mean, it's all a matter of malaligned relative to what? In tricuspid atresia, as Justin showed, there's no question that the atrial septum is malaligned relative to the ventricular septum, because the point you just made, the ventricular septum does not come to the crux. But when you look at the atrial septum vis-a-vis the left ventricle, then it does not seem to be malaligned. So malalignment in itself is a difficult entity, and we're only scratching the surface. But I mean, the point we were trying to make today is that malalignment needs to be put into the context of the specific defect, because malalignment is not a phenotypic feature. So to say something is a malalignment defect really tells you very little about it. Only when you know the geography and the borders in the setting of malalignment can you get a handle on what's going on.
And one last thing, do you think that looking at the coronaries, the main coronaries on the surface of the heart, will help in terms of describing better?
Absolutely. And I mean, that is the delimiting arteries. They show you the location of the ventricular septum. And when Andrew showed you the plane of the septum, he showed beautifully that the incomplete right ventricle is carried anterosuperiorly, the incomplete left ventricle is carried posterior-inferiorly, and the coronary arteries are indeed the guide to that. Sure. Diane has been there listening very faithfully to all of this. Diane, do you have any comments, or would you like to make any suggestions?
Well, I agree with Adrian's comment about the coronaries and your description of how they lie over the septum, because I use that constantly at autopsy as one of my preliminary hints to what I might be looking at in any patient with congenital heart disease. So it's a good, helpful hint to look at the coronaries. I also think that for everyone who's listening out there, that the vestibular spine and the part it plays with creation of the septum of the atrioventricular canal is something new, and people haven't paid attention to it so much in the past. And I think now that with these discussions we're having, that it's a very important structure with septation.
Absolutely. I note on Sasha has kindly made me the host at the moment. It's very encouraging to see that we still have the larger part of our participants still with us. And I have a question here from Mateo Rios Valdez, which is a very good one. I think there is always some confusion with Eisenmenger defect and physiology. Could you shortly clarify? Well, to me, the Eisenmenger defect is an anatomic defect. Justin, you're more aware of the defect.
Yeah, I 100% agree, Matteo. Every time I say Eisenmenger defect, in my mind, I think that's going to cause confusion in people, because you don't learn about that in medical school or in your fellowship often. training, you learn about Eisenmenger physiology, and that's where everybody's mind goes to. So I don't know the historical context. Professor Anderson can tell us the historical context, but I don't like the name Eisenmenger defect. I think we describe it as a perimembranous outlet VSD with anterior malalignment of the outlet septum, but important difference from tetralogy of flow, where that is the main defect, is that the infundibulum is well formed. There's not septal-parietal trabeculation hypertrophy or resulting RVOT obstruction. Important for the patient is that I think it's a very different stigma to have tetralogy of flow versus a VSD. So if you can make that differentiation, I think that's important. But I think it's still a question, can a patient that you're calling an Eisenmenger defect, there's no RVOT obstruction, the infundibulum is well formed, can they subsequently develop RVOT obstruction, and are they really on the pink spectrum of tetralogy of flow? I think that's a gray zone as well. So that's my opinion, is I would avoid calling it an Eisenmenger defect, and I would describe it as it is to avoid that confusion.
Norman, you must.
Yeah, I agree with Justin. It's unfortunate that nobody actually knows about Eisenmenger VSD. To me, an Eisenmenger VSD could be equally confusing as an echocardiographer. It's tetralogy without the anterior superior deviation of the outlet septum, and it's with a perimembranous VSD. So, I mean, I guess it's rare enough that it's not a frequently confusing phenomenon, but I think that your description of it as a perimembranous VSD and outlet VSD without subpulmonary stenosis is probably the best way to describe it.
But did not Paul Wood introduce the notion of the Eisenmenger reaction, which you could have at various levels within the heart, even with a persistently patent arterial duct and pulmonary vasculature as secondary to the shunt? Is that not what Paul Wood called the reaction?
I can't remember that far back, Bob.
Goodness me, Norman, if you can't remember that far back, what chance do we have?
That's right.
Your mentors, Abe and Julian, trained with Paul Wood.
Yes, they did. Well,
You must know something about that. Adrian, you must.
I think there is an important distinction here, whatever we call it. The Eisenmenger defect has that anterocephalar deviation of the outlet septum without obstruction in the outlet. But there are outlet defects, muscular or perimembranous extended, that don't have a deviation of the outlet septum. And I think that's where it's interesting to discuss what happens with this outlet septum in those defects that are outlet but without deviation.
Good point. But what about the Eisenmenger reaction?
I've never heard of it until today. So
I'm having a reaction to this Eisenmenger reaction.
yes.
Different than Eisenmenger physiology?
Well, I think the Eisenmenger physiology is the consequence of the point about that Victor Eisenmenger made when describing his heart was that despite the anterior deviation, you had unobstructed flow into the lungs, and that could then lead you to pulmonary vascular diseases. And I think it's the pulmonary vascular disease, is it not, which I think Paul Wood identified as I might have missed.
Yeah, Eisenmenger physiology, which is what everybody learns about, is exactly what you're saying, the development from a left to right shunt, which could be any kind of VSD, so it doesn't need to be an outlet.
Or an arterial duct, could it not?
Yeah.
Anything.
Any left to right
Anything.
shunt.
AP window, the whole works.
Yeah, that's
As long as it has to be post tricuspid though, does it not?
You could have it with a ASD, and because you're gonna overload.
It's unusual though. Yeah, I think in all fairness to Bob, it is unusual. The pulmonary hypertensive reaction in atrial septal defects is usually pulmonary thromboembolism as well. So there are different causes for pulmonary hypertension, but I guess that we dropped the term Eisenmenger syndrome for pulmonary hypertension these days and pulmonary vascular disease because of the advances that have been made in the treatment of pulmonary and management of pulmonary hypertension.
And
So
I think we should likewise drop it in the anatomical description because as
Correct.
we point out,
It's a case of an eponym being a confusion thing.
You have to cut a little bit of slack, Justin, for those of us who grew up in the previous eras.
To make it
Can I
easy,
just ask one important question to you guys?
Hang
Bob?
on a moment, Norman. I've got another question here from Miguel Angel Arizepana Arapa, who is asking, over time, the atrioventricular valves have myxoid degeneration. What histologic changes are seen in heart disease with atrioventricular septal defect? Diane, you see this all the time, where you see them more as you're doing the autopsies. How would you, it's mucopolysaccharide deposition, is it not?
I'm not sure what the deposition is, but it just depends. Sometimes I see it at the outset, very close to birth, and other times it's following surgical repair and longstanding turbulence over the valvular inlets. So it varies.
Right. Okay, Norman.
Well, so just to follow Diane's point, I mean, I think that the issue of birth in terms of development is not big for the fetus in the sense of its valvular development and diseases. So we can see valves that in utero, for example, the tricuspid valve, pretty beat up, thickened, and have excrescences on it, and follow these patients after birth, and some of this abnormality can resolve, in fact. So there's a dynamic process in terms of issues that occur on the valves. I'll defer to the histology because I don't generally follow histological issues.
Neither do
But
I. So
my issue here, Bob, my issue here for you and Justin is we're talking about anatomy of the conducting tissue. And as far as I understand it, the electrophysiologists have three-dimensional data sets that they can look at to show the conduction within the heart. And Justin, this is particularly in your bailiwick. Do you think that perhaps having a sophisticated three-dimensional electrophysiologist come in might be helpful in terms of looking at this, or do you think this would just further complicate and confuse the matter?
Yeah, that certainly is all the rave, the intraoperative mapping that's starting out of Boston. And I've seen that presentation at the World Congress with the multidimensional anatomy lab that we're creating there to demonstrate all the high-tech three-dimensional imaging, surgical planning. We're going to have the group from Boston teaching how they're doing that. So I'm very familiar with what they're doing. I think that it's complementary. If you look at the probes are pretty large. And if you, depending on the child or the young adolescent or adult heart, you're going to be scanning a large area. I think that they can pinpoint very crudely and in a general aspect where the conduction axis is lying. But what we're trying to do is to look at where is the AV node, where is the penetrating bundle, which we would describe as solely the point of penetration from the atrial to ventricular mass. Where is the non-branching bundle? Where are the origins of the bundle branches in their superior fascicles? To really get to that level of detail, which becomes important when you're trying to do things not only in our realm with congenital heart disease, but things like TAVR, which still have a very high incidence of heart block. So I think it's complementary, but I don't think it's as precise as where we need to be.
So it's not ready for prime time in terms of a simple analysis.
Yeah, I think that those are the tools that we have largely available, not as much the intraoperative mapping that requires a lot of a learning curve and the equipment and so on. But the three-dimensional mapping that you're talking in the EP lab, that's certainly for some of these higher risk cases that have malalignment, congenitally corrected transposition, for example, where there may be higher risk for heart block related to various procedures, then that is always in the preoperative planning discussion of EP mapping and so on. So I think that certainly is one of the main tools that we have at our disposal, but there's always room for improvement, and that's what we're trying to do.
I mean, I would come back to the fact that with the ability now that you've shown to illustrate the arrangement using CT data sets, I think you can pinpoint, if they're going to do their mapping, you can pinpoint exactly where they should be putting their probe. And I think you can use the gross anatomy to guide as to where the conduction system is likely to be.
Absolutely.
When they go into the operating room, they can then be more precise, knowing where to put their probes.
Absolutely. And we've been doing that with more complex cases, congenitally corrected transposition, for example, where if a lot of times they've had a CT. So, I mean, that's what we do a lot, is we maximize the use of data that's already been obtained, and we'll create these kind of reconstructions. We'll estimate where we think the structures are, and then we can overlay that onto, often they're doing without fluoroscopy, but we'll overlay that onto their Caudal machine, their three-dimensional mapping, to help to guide the procedure better and be more precise.
I remember Chris Lincoln saying that he didn't have to worry too much, because if he had a complicated case, he took Bob Anderson with him into the operating room. And now I think we have to transform that to say, you don't have to worry to take anybody into the operating room, because you take the images that Justin Tretta has given us and take them into the operating room, and you do just as well.
Yeah, and there's a lot of people out there doing similar things. And I would mention, because this has come up a lot with this audience, about learning these specific techniques. Again, the World Congress that I mentioned, Washington, D.C., in end of August, early September 2023, we're going to have this very nice multi-dimensional anatomy lab. Diane Spicer, Andrew Cook, and Adrian, and hopefully we can get Professor Anderson there, and Norman will be there. We'll have heart specimens, but then we'll be showing all the latest, greatest 3D imaging technology, 3D printing, virtual reality. But you'll have the opportunity too, if you want to learn what I'm doing, we'll have the company I work with there and it's going to be more of this lab will be very practical. It'll be, how do you incorporate technology X, Y, and Z into your imaging program?
It all sounds very exciting, but I think it's time for me to hand over to Adrian and to Diane at this stage. And Andrew, if you can get Andrew there, I think that I will be happy to look at what's going on from London from the golf course.
Well, very good. The most important thing today is the new definition of tetralogy is an Eisenmenger defect without an Eisenmenger risk of physiology because of outlet obstruction. Yeah, let's make it simple.
Hey, if I could make another comment about the atrioventricular valve question, you also have to consider chromosomal abnormalities with changes in the valves, because very often with trisomy 18, you see polyvalvular dysplasia, and of course with trisomy 21. And I've heard the surgeons talk very often about waiting on premature babies or babies that aren't doing so well to wait until the atrioventricular valves have matured a bit, because the surgery goes much more efficiently when you have a valve that's stronger and has grown with the baby.
Well,
it's a very good point, Diane. And we know that the valve continue to remodel and sculpt, and long after the final phase of the construction is done.
But there's a corollary to that statement, Diane, and I will quote Dr. Frank Hanley on that, my colleague, where he said, for example, with Epstein's malformation, that if you wait too long, the valve becomes very deformed. And so there's obviously a time when the valves can mature and change their characteristics But if you wait too long, then the valves start to degenerate and the results cannot be as good as when the valve is in a more pristine state.
Well, Norman, I think we will leave you having had the last word today. It's been a long session. We've been at it for nearly 2 hours. Thank you all for your comments. Thanks to all the participants who are still with us. It's very encouraging to see that more than 4/5 of our participants have stayed with us for 2 hours. And as you've commented, Norman, the material is now available on the Congenital Heart Academy website, so everybody can check up on what they've heard today. Grace tells me that many people now are waiting until we have made this recording, and then they are tuning in later at their own pace. So thank you all.
Thank you.
Next time,
Thank you.
Diane, Justin, and I will hopefully have put everything together. If all goes according to plan, I shall be in Florida next week with Diane. So looking forward to being with you guys. And Adrian, have a good time in Paris.
Yes. Yep.
Okay.